Welcome. I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Joining me today to discuss the growing epidemic and abuse of the sedative Xylazine, street name Tranq, with its unique skin findings is Dr. Joseph D'Orazio, Associate Professor of Emergency Medicine at Temple University and Director, Division of Medical Toxicology and Addiction Medicine. Welcome, Dr. D'Orazio.
Thanks for having me.
It's very important that we discuss a growing trend. It's been noted, especially in Philadelphia, and you're quite aware of this, of the drug Xylazine. I want to ask you, how did it come to be a drug of abuse?
Well, it started mostly in Puerto Rico in the 2000s. I think that's sort of our first knowledge of this drug being used recreationally. And it really, made it to Philadelphia in as early as 2006. Typically consumed with opioids together as like a unit, like fentanyl and xylazine together. In Puerto Rico, we do have some knowledge that it was used the same way, and then sometimes people were using that drug primarily.
What is the mechanism of action of the drug itself, and what's the reason it's being cut with fentanyl and heroin? Because certainly it's gotten into the U.S. supply pretty rapidly.
So it's a sedative, and in all intents and purposes, it's an anesthetic, and that's what veterinarians have used this drug for a long time for. To do procedures on, on a cat or a dog or a larger animal. They've used that drug to sedate the animal to do a procedure on, and so it acts in similar ways in humans. It's a sedative, sort of looks like a benzodiazepine from the outsider, but it actually works at a very different receptor, so it doesn't work at the benzodiazepine receptor like other sedatives do. This is at the central alpha-2 agonist receptor. So there are other medications that are similar to this drug, like clonidine or dexmedetomidine, that work at the same receptor. But this is a veterinary drug. No, we don't have much experience in humans. And this is not a drug that is produced clandestinely like fentanyl. This is a product that is coming directly from veterinary supply into our opioid supply.
So what are the signs and symptoms we see clinically of a xylazine-involved overdose?
Sedation is the major thing that we are seeing. So on the low end, someone who has used xylazine can be sleepy, and then on the high end, they're unconscious. We are not seeing respiratory depression with this drug. The thing is, though, that this drug is commonly used with an opioid, so it's not uncommon to have respiratory depression from the opioid that the person is using.
And so obviously naloxone is given in any suspected opiate overdose, but in truth, obviously it's not going to make any difference in the outcome. Do you still recommend that it be given in this sense?
Absolutely. Just remember that these drugs are used in unison. We're not really seeing people who are using xylazine alone. It's always with an opioid. So if you encounter somebody with an opioid overdose, giving naloxone to restore respiratory function is the most important part of all of that. Now, the major point here that I want to bring up is that we're so used to giving naloxone to patients who have an opioid overdose, and for them to restore their breathing, and then with that they wake up and talk to you. But we're seeing a lot of sedation even after giving naloxone. So really titrating the naloxone to respiratory depression and hypoxia, and so making sure that you restore that respiratory function, but just be aware that they may not wake up and be communicating with you initially. And so giving supportive care in that scenario rather than giving more naloxone is the answer.
So given that the drug obviously produces heavy sedation, is there any reversal agent that has been at least entertained or looked at? Certainly in the animal literature, at least I'm aware of a few of them, but can they be given to humans?
There is no medication that is approved for xylazine reversal. There are certainly drugs out there that people have thought about or I'm sure brought up. So one is euhimbine. We've talked about that with clonidine reversal, but that is not recommended. And etipimazole is another drug in the veterinary literature that is used for reversal in animals, but it is not a drug used in humans, so it is not recommended. But I guess maybe the question I would want to bring up is, do we need a reversal agent for this when supportive care is usually enough, especially in controlled monitored settings? I would bring up the same sort of care for how we manage patients with clonidine overdose. Naloxone sometimes has some controversial use in that care. Mostly, it's supportive care to manage this, and this is what we need to do with Xylazine overdose.
I want to switch gears a little bit and talk about the skin ulcers and skin findings that have been described. And the question I have for you, does xylazine actually cause these ulcers and abscesses and in some cases tissue necrosis, or is this more of an association? Has that really been sort of studied at this point?
We don't have any studies looking at directly at this, certainly not in human literature. There is some data from animal literature, veterinary literature that says that it does cause some skin necrosis. I think we're still trying to figure that information out. But there are necrotic wounds that have been associated with its use, rather than like skin infection and abscess. I mean, certainly that is a problem with injection drug use in general. But the skin necrosis that we're seeing associated with xylazine, there's been a major increase. And you gotta think that there is some association with this drug. I'm not quite sure the underlying pathophysiology of why it's causing skin necrosis. And it may also have to do with a little bit of the behavior involved with using this drug too.
So what I had been reading is that even if you smoke or snort the drug or swallow it, the incidence of these skin findings, is independent of the mode of how you use the drug. Any insight on that?
Most of the patients that we encounter that have skin necrosis is due to injection drug use. So we're seeing a little less patients who are snorting or smoking fentanyl and xylazine. But we also hear a lot of reports of inject in one area and I developed a wound in a separate area that I never inject in. So I think that's sort of a corollary of what you're sort of describing. Like it's not necessarily just a local effect of where that drug was injected. And I think we have a lot of concern about that also. Though if it was a systemic effect, you would think that you would develop skin ulcerations, necrotic wounds sort of all over your body in a uniform pattern, maybe symmetrical. But what we mostly see are wounds on extensor surfaces, on forearms and lower extremities, which is, I'm not quite sure I understand the underlying cause of that, but it's certainly not a wholly systemic effect.
So the thing that we've been seeing are amputations that are arising from use of xylazine. And given that peripheral vasoconstriction is one of the mechanisms, of the alpha-2 adrenergic agonist, would that necessarily be at least some of the explanation related to the amputations?
Yeah, I don't think it can wholly explain the reason why people are developing these wounds. Certainly, we see people with proximal wounds that develop, and not necessarily in the hand or the foot. And that's where you'd expect if it was just really due to vasoconstriction. But then also there's a component of infection that develops. So after you develop this necrotic chronic wound, oftentimes get infected, and that's sort of the secondary hit that leads to end up patients with like a necrotic limb that requires amputation. We see all sorts of injuries and infections and wounds. Sometimes we see patients who have necrotic fingers, but that doesn't necessarily directly correlate to xylazine use. Sometimes that's like injection into an artery, like a radial artery, and then you lose 3 fingers. Or maybe you have a wound on the dorsum of your hand that develops and causes some deep infection, and that requires a hand amputation. But sometimes we're also seeing forearm or lower extremity wounds that's more proximal that develops, and it becomes so severe you lose function distally, and then that requires an amputation when it's severe.
My other question is it causing any organ ischemia, splenic infarcts, mesenteric ischemia, any issues in that capacity? Are you aware of that?
No, we haven't seen anything like that. Certainly we see patients who come in after significant hypoxic injury from opioid overdose that's associated. And so toxic brain injury, cardiomyopathy, acute lung injury, AKI, so on and so forth. But I would assume that's more related to the opioid overdose rather than xylazine use.
Got it. So obviously, there's no current way to test for xylazine that I'm aware of. How about on your end? Is there anything in the pipeline or anything on the horizon that you see?
Yeah, there certainly is a way to test for xylazine. I can't say it's really effective for bedside management. They're mostly through forensic labs. So it's a send out lab that's typically doing some more higher end techniques that'll take sometimes days. So it doesn't really help you at the bedside. Um, and there is a lot of talk about a point of care test coming out in the very near future, and hopefully we that's going to be available to us as an immunoassay, as a point of care test for a harm reduction, also for the community people who are injecting drugs.
Yeah, because according to a recent article, in 2021, up to 90% of fentanyl and heroin samples were contaminated with xylazine, making this really problematic. So if you had a test strip, similar to a fentanyl test strip, would be very, helpful, certainly for anyone who is, injecting or using fentanyl or heroin for that matter.
I think in communities where they're rarely encountering xylazine, it'd be really helpful to steer away from it. Certainly in my community in Philadelphia, where all of the bags of opioids contain fentanyl, fentanyl testing really isn't so helpful anymore because all of the bags have fentanyl in it. And we're at that stage too, where almost all of the bags have xylazine in it. So it's not really so helpful, but probably more for communities that are seeing it here and there. They can test for it, and then you can have an informed decision whether you want to use that dose.
The half-life, I believe, is 25 to 50 minutes, give or take. So really testing for it could be problematic. I wanted to move into the issue of withdrawal from xylazine for frequent users. So that's been written about as well. And have you experienced that clinically in terms of taking care of patients seeing this type of withdrawal?
Yeah, we see a lot of that. Yeah, there really isn't much. You certainly can't find it in a textbook. I think we have a little some corollaries to help us define it when we're looking at clonidine and dexmedetomidine. Uh, we do see a significant portion of that. The sort of it's unlike benzodiazepines where we don't see a lot of tachycardia, hypertension, diaphoresis, seizures that you would expect from other sedative hypnotics, or even like alcohol. But it does cause a significant anxiety reaction, and so lots of dysphoria, restlessness, and it's difficult because those are two symptoms that overlap with opioid withdrawal. But what we have seen is that even if the opioid withdrawal is managed really well, the patients are left with this restlessness, anxiety, dysphoria. So it can be very difficult. And actually, many patients will report that, many providers don't know about xylazine withdrawal. And so it gets undertreated. And that has led to patients avoiding hospitals and inpatient drug rehabs because of their fear of xylazine withdrawal.
Right. I think it's an important point you raise. It should be on all clinicians' radar, especially when a patient comes in with hypotension, bradycardia, cardiac conduction disturbances. At least consider this as an adulterant in someone who presents with an opiate overdose.
There's really no drug that has been identified as the standard drug to use in this scenario. Giving back medication that works at that receptor would sort of make sense. But I think what we're seeing is that xylazine is used in a degree of magnitude higher than any of our other alpha 2 centrally acting agonists. And providing too much clonidine can cause some bradycardia and hypotension. And we're just never able to give enough of our pharmaceutical drugs that work at that receptor to suffice the dependence or the withdrawal. And so we have to use other medications. And we really have relied on using supportive care medications like benzodiazepines to manage a lot of the xylazine withdrawal.
This is great. Would you be able to give us a few pearls just to take away in terms of xylazine management and sort of give clinicians just an overall picture of what we should really be focusing on?
Yeah, so I think if you are encountering a patient who is using fentanyl and xylazine, or is suspected using xylazine with their fentanyl, Remember to expect that providing naloxone may restore respiratory function, but may not necessarily restore their mental status. And providing more naloxone may not necessarily reverse that, since naloxone doesn't work at the alpha 2 agonist receptor. And we see a lot of wounds, making sure that we're addressing wounds. And then withdrawal for the inpatient side too. So providing benzodiazepines as supportive care to manage tranq withdrawal.
Great. Well, I appreciate your time. This has been very helpful. It was very helpful for clinicians at the bedside, especially in the emergency department. Thank you again. Really
Thanks for
appreciate it.
having me.